scientific content and medical information getting completed and move ahead. And breast cancer is a portfolio something which is we are definitely very strong on. And it is our first flag of meeting which is in a larger scale on breast cancer for the year. So I'm looking forward for many more interactions. And without much ado, I hand it over to Dr. D.C. Dole to coordinate. Over to you, sir.
Good evening to all of you, and I welcome you for this meeting on breast cancer. And as you all know, because it's a difficult time, COVID now, and we are forced to stay back home or stay at the workplace, not seeing many patients, and trying to make the best use of our time. And this is one of the best uses. The webinars have really increased over the last 1 month, and there's almost no day when there is no webinar on oncology and ASTRO and different kinds of things. So this was, let me welcome you all to this public meeting, which we have 2-3 lectures and 2 panel discussions are there. Unfortunately, due to certain unavoidable reasons, Dr. Manish Singh could not be joined, but we have a propensity of Manish's or Manishas to cover the program. We have Manish. So the first lecture will be by Dr. Manish Garola, and this session will be chaired by Junta. Is he around, or otherwise I'll invite Dr. Manish Garola, who will be giving a lecture on updates in the management of breast cancer, ASTRO and ASTRO Guidelines. Dr. Manish Garola, please.
Thank you, sir. Rajesh, will you load my slides?
Yes, sir, we will.
Thank you. Thank you, sir, for the invitation and giving me this opportunity. I would be dealing with the talking to updates in the management of breast cancer ASTRO and ESTRO guidelines pertaining to this thing. May I have my first slide? Just to give a brief background, we all know that breast cancer is a global disease which has high incidence and thereby requiring high attention both clinicians and of course research academicians. As per the recent World Census, Asia comprises the maximum number of cases of breast cancer, and of which India takes a major chunk. Next slide, please. With 7.8% share in incidence, India has relatively high mortality, which stands for about 13.9%. This is a global consensus, and we might underrepresent the actual numbers. We also need to understand that breast cancer is a systemic disease with high local regional failures. With such high numbers in both incidence and mortality, we need to strengthen our local regional treatment modality to enhance the outcomes. Next slide, please. Yes. ASTRO has come of series of consensus guidelines for different clinical scenarios, particularly addition, quality of radiation therapy. Next. Yes. I will be primarily focusing 2 major guidelines. Next. First one is the latest update on how to irradiate the whole breast, and number 2 is post-mastectomy radiotherapy, also known as PMRT. Next slide, please. Again, the ESTRO has also issued a series of guidelines in conjunction with ACROP and JAC groups, and these are primarily related to the technical aspect of addition of radiotherapy. It focused on contouring in different scenarios like intact breast, brachytherapy, and in cases where immediate reconstruction is done post mastectomy, various techniques, and setup verification. ESTRO primarily focuses on the standardizing radiation treatment so that an improvement can be foreseen in the unidirectional manner. Next slide, please. They have primarily asked 5 questions pertaining to decision making of start, doses, and treatment volumes for intact breast. The data is primarily collected till mid 2016 and then analyzed. Click, please. Yes. And the ASTRO panel has assessed the data in terms of overall survival, disease-free survival, recurrence, acute and late toxicity, and of course the quality of life in these patients. Next slide. The initial task force was made in 2011. Similar questions were asked, which will be discussing that I will be discussing in next few slides. The major change in the recommendations lies in the strength of the evidence which has increased now. The 2011 task force was initially made to probe in the new idea of hypofractionation in breast and formulated working guidelines for hypofractionation to be used in clinics. Next slide, please. This is the updated recommendation from ASTRO panel, which was published in 2018. It primarily focused on hypofractionation. For those who are not radiation oncologists, let me explain the hypofractionation. Hypofractionation means the treating the area intended with high dose per fraction with lesser number of fractions in total, thereby delivering similar radiological effect. Next slide, please. ASTRO panel, in fact, formed 5 basic questions and took a consensus on the available evidences. Question number 1 is pertaining to dose fractionation scheme in whole breast. Does this recommend fractionation change with different tumors or patient profile? Question number 2 was related to the tumor bed boost. And what are its indications? How to effectively irradiate the tumor bed? Next slide, please. Question number 3 was, when treating tumor bed, what fractionation is adequate, and in what sequence to the whole breast radiation should be employed? Question number 4 and 5 are related to the technical aspects of delivering radiotherapy. Next slide, please. As of 2018, the question hypofractionation for whole breast is undisputed. You can either treat with START protocol or with Wilhelm protocol in 15 or 16 fractions. This treatment protocol, if you see, is irrespective of the low axillary coverage. However, we need to cautious in patients who have heavily studded axilla or where we intend to treat level 3 or SCF or IMC nodes. Even though small clinical studies have pointed out the safety of hypofractionation in regional nodal irradiation, the data is still lacking of level 1 recommendation or a stamp. However, the panel recommends the use of hypofractionation independent of grade, margins, hormonal status, age, histology, laterality, breast size, use of chemotherapy, and of course DCIS. As you know, and you can see here, the recommendation strength is strong. Uh, you can see recommendation is strong with high quality and 100% consensus on this stake. Next slide, please. Question number 2, which addresses the issue regarding the tumor boost. The indications are clear and have a strong recommendation for the PAN. In cases of IDC, any of the following is mandatory, like age less than 50 years of age, high grade, positive margin, either focal or persistent. For DCIS, any one of these characteristics are mandatory, like age less than 50, high grade, close margin, or positive margin. Next slide, please. See the question number 3, the dose fractionation in cases of tumor bed boost is, it was on tumor bed boost. The absence of strong risk factors in cases where there is no strong risk factor is there, then sequential boost 10 gray 5 fractions was adequate. While in presence of strong risk factors, either sequential boost where the dose was 14 to 16 gray, or sequential boost where 12.5 gray in 5 fractions was recommended. In fact, we still do not have level 1 evidences of safety treated whole breast and boost simultaneously, and therefore the guidelines recommended treating them one after the other. However, newer data is coming up where incorporating boost simultaneously with whole breast is safe and feasible. Hopefully, with the upcoming trial results like HypoSIP trial, we can change the level of recommendation. This trial is about to finish in 2023. Next slide, please. As I said, question 4 and 5 are technical questions where the consensus lies with various checks and safeguards in treating breast, like maintaining dose homogeneity. Strict parameters are mentioned here. Other things like cardiac delineation and avoidance, setup reproducibility and image guidance, and of course to protect the normal tissues. Next slide, please. Yes, this is the difference between 2011 and 2018 ASTRO guidelines in a nutshell. ASTRO panel now strongly recommends hypofractionation irrespective of any age, any stage. Here I want to highlight, I want to mention that as long as you don't need to treat high level of regional lymph node, any stage is recommended for hypofractionation. And of course, any chemotherapy is also comes in this category where hypofractionation is recommended. Next slide, please. This was the study conducted by UK group called FAST Trialist group, and they included patients with node negative early breast cancer in women with age more than 50 years of age, and the primary endpoint here was in this study was the 2-year cosmesis. Next slide, please. Yes. The patients were divided into 3 groups. Next. Yes. They are divided into 3 groups. First is 50 gray in 25 fractions. Second is 30 gray in 5 fractions. This was 1 fraction once a week. And third fractionation schedule was 28 gray, 28.5 gray in 5 fractions. Again, 1 fraction in 1 week. The endpoint was assessed via photographic appearance of breast at 2 years. Next slide, please. Even though 28.5 gray, next. Yes, even though 28.5 gray arm was comparable for 50 gray, the concept was never adopted in mainstream clinic as data presented only early cosmosis results and did not have any survival outcomes in this study. Plus, one fraction once a week was logistically viable as patient coming from from very far and had to travel every week rather than completing or getting treatment in one go. Next slide, please. This is again the ongoing trials. Next slide. This is actually the fast forward trial and was initiated with the intent to assess the extreme hypofractionation, a treatment which will be completed by 1 week in comparison to 3 to 4 weeks. Patients were divided into again in 3 arms: 40 gray in 15 fraction, 27 gray in 5 fractions, and 26 gray in 5 fractions. At 5 years, IBTR was similar in 40 gray and 26 gray. With such promising results, the possibility of inclusion of such phase 3 data in guidelines is always there. However, we need to cautious and wait for the data to mature, as patient included in this trial was early T1, T2 lesions, node negative, where the follow-up should be long enough to derive any meaningful results. Next slide, please. ASTRO, next slide. ASTRO has issued guidelines for PMRT also. Means post-mastectomy radiotherapy. Next slide. Again, there were primarily 4 questions answered in these guidelines. Question number 1: is PMRT indicated in patient with T1, T2 tumors with 1 or 3 axillary lymph node positive who undergo axillary lymph node dissection? Question number 2 was: is PMRT indicated in the patient with T1, T2 tumors and a positive sentinel node biopsy patient who do not undergo completion axillary lymph node dissection? Third question was: is PMRT indicated in patient presenting with clinical stage 1 and 2 cancer who received a neoadjuvant chemotherapy? And question number 4 was: should regional nodal irradiation include internal mammary lymph nodes and or supraclavicular axillary apical nodes when PMRT is used in patient with T1, T2 tumors with 1 or 3 positive axillary lymph nodes? Next slide, please. PMRT in 1 to 3 nodes is long burning questions and has not yet been answered completely. We all know that. There are always arguments and counter arguments for using PMRT in such conditions. Older data including the recent update in of EBCTG are clear regarding the need for adding PMRT in such conditions. They have shown benefits in terms of loco-regional control and breast-specific mortality. However, the argument against PMRT, that is age is that in the age of new surgical techniques and contemporary chemotherapies, the need of PMRT, especially when we all know that it on the left side it may increase the cardiac toxicity, is really worthwhile or not. However, we must keep in mind that radiation techniques have also improved, where we can control doses delivered to the heart, both by employing modern techniques and breath holding modalities, which are also available nowadays with us. Nonetheless, the clinical practice requires all the oncologists understand the risk adaptive approaches, where might be certain cases we don't benefit from PMRT. Next slide, please. So the panel recommendation, the panel anonymously agreed that the available evidence shows the PMRT reduces the risk of local regional failure, any recurrence, and breast cancer-related mortality for patients with T1, T2 breast cancer and 1 to 3 lymph node positive. However, some subset of these patients are likely to have such a low risk of local regional failure that absolute benefit of PMRT is overweighted by its potential toxicities. Next slide, please. Now, the question is again the PMRT in clinical stage 1 and 2 receive those who have received NAC or neoadjuvant chemotherapy. So in this, if axillary node persists after NACT for stage 1 and 2 and high risk factor for local renal failure over there, then these kind of a patient should be irradiated. No, in fact, no randomized controlled trial is available, but there are a lot of series which are available which answer this question, and that is why the panel recommends that patient characteristics and disease profile is most important in answering this question. Next slide, please. Now we are waiting for this MRC Supremo trial to come up with their results. It is, in fact, it is a phase 3 trial which is waiting the results, the data to get matured. Its primary endpoint is OS and secondary endpoint is DFS. It included patient with gray area profile, stage 2 with 1 to 3 lymph node positive or lymph node negative patients, but having high risk features. Here, patient with post NACT were also included. Next slide, please. Yeah. Even though we are waiting for the primary data and results to come out, they have come out with interim results on quality of life indices. It's 2 years follow-up and have showed that post-mastectomy radiotherapy led to more local symptoms up to 2 years post-randomization compared with no radiotherapy. Compared, the patient did not get any radiotherapy. But the difference between these two groups was very small. What was interesting to note that the chest wall symptoms were highest when both radiation and chemotherapy were used. Next slide, please. ESTRO has come up with consensus guidelines on how to delineate target volume for early stage breast cancer. In fact, it's a vessel-based guidelines and have clearly mentioned regional nodal anatomy. Next slide, please. Next. Yes. Like intact breast. Oh, sorry. No. Above. Next. Before. One slide before. No. Before. Yes. Like intact breast guidelines, ESTRO has also published consensus guidelines for tumor bed implant brachytherapy, the target delineation, and the doses. They have outlined the brachytherapy parameters and the instrumentation procedures and reporting measures as well. Next slide. Next. Yes. If you see the recently consensus guidelines have come up for target volume delineation in the setting of post-mastectomy radiation therapy. They have mentioned the area that need to be treated with higher chances of failure. There is no need to treat the entire volume, but only the skin flap area. However, cases with retropectoral implant positioning, either partially or completely, we need to alter our contours and include the post-implant space as well. Certain high-risk features like invasion of pec major or chest wall also warrants us to extend our contouring over our contour so that we can in this area and there are very less chances of missing these areas. With this, I would like to stop my presentation here because I think otherwise it will go very long. Thank you very much. Thank you, Dr. Doval, for giving me this opportunity. Thank you, sir.
Any questions for Dr. Garula on the chat box, please? Okay, if there are no questions, then I would invite Dr. J.S. Seko. Dr. J.S. Seko, please. I don't see him. Dr. Seko is there, please. So the next speaker is Dr. Ramesh Nimagada, and Dr. Ramesh Nimagada is known to everybody in this crowd, and he is the senior consultant with the Apollo Specialty Hospital, Chennai, and he has been instrumental in a lot of data collection, and we have done data collection, the OncoCollect, which has been a software which was conceived and further matured by him. And I think today he'll be talking to us about this data collection, how he has done, and how we could bring out a good paper from India. Dr. Ramesh, please.
Good evening, everyone, and thank you, Rajesh and Dinesh. I think, not sure, am I sharing the screen or?
I can see you.
Yes, sir. You can.
Okay, I'm sharing the screen. Okay. Share, yeah. Okay, now I think you can see these slides?
Yeah, we can see the slides.
Right. Then this is the insights from Indian data of breast cancer patients, quite a lot we published in Nature Scientific Reports. And this is primarily data from Dr. Dinesh Doval and Selvi Radhakrishnan. Really, mine was around 200 plus, and I really put it together. That's what my primary thing is. Then this was published in. I'm not able to move this. Yeah, no. Yeah, this is a multi-institutional real-world data study from. I get off my. Yeah, oh, I'm fine. Thanks. Multi-institutional real-world data study from India of 3,453 non-metastatic breast cancer patients undergoing upfront surgery. And this was published in Scientific Reports in April. And I must thank really, of course, Dinesh and Selvi, as I said, but really Sudeep Gupta, as you all know, he really is the one that put this together for us. One day we met in Coimbatore in one of the meetings, Dinesh and myself with Sudeep. Looking at the data, he said, this is something we should present differently. And really, he said how to go about doing it. Thanks, Sudeep, and that was really something we probably wouldn't have been able to do without you doing that. And also, he helped us along with the manuscript and going advising. And Rupal for really writing the base and as well as really going through a lot of journals. Obviously, we did few of them before we got this one done. for formatting every time and submitting. Now the data we collected is from 2008 to 14, patients who had upfront surgery. All three of us were kind of collecting and keeping in Excel, and I was keeping in my software, and we put everything into the software, and then again further enriched, going through again one more review of charts for any missing things, and finally we completed the whole thing. And that was about 80% of all the treated patients we had that had the upfront surgery, but all the patients who had upfront surgery. The other 20% are, of course, looking at the Doug Selvey being a surgical oncologist, and the two of us in primarily this trust-free practice, the stage 3Bs and 4s are less. Microsoft R Open was linked to OncoCollect for doing the statistics, and all these tables and statistics, everything was done by myself, and in fact, it is quite automated in our software with the linkage. And the results, if all of you or some of you have looked at the article already, these are the clinical tumor profile of all the patients. But in this, one of the things I would like to really point out is that the patient, the size of the tumor, pathologic size of the tumor, and I think we can enlarge it for you. One advantage I think we all have with this presentation, and as you can see, less than 2 centimeters is 670, and in that actually less than 1 centimeter is about 85 patients. So most of them nearly 600 are 1 to 2 centimeters. I want you to keep this in mind, and 2 to 3 centimeters is the majority, 40%, and 3 to 5 centimeters, I split this, I'll tell you why it is, and about 1,000 patients, and more than 5 centimeters is 2,040. And if we look at the lymph nodes, positive lymph nodes are quite equal to almost 50-50. 1 to 3 is quite high. In fact, the 4 to 9 nodes are interestingly are not very high. It's only near about 11%, and the more than 10 nodes are of course 8%, pretty well. So really majority of the lymph nodes are 1 to 3. That also is quite a favorable thing in our patients. And then when you come to the receptor subgroups, the ER/PR positive or to negative is 55%, and ER/PR positive and HER2 positive are ER/PR positive or negative, and HER2 positive primarily is 654 or 20%, and triple negative is 769, 24%. And there are here and there few missing, as you can see, 3174. So roughly about 5 to 10%. We lost. We don't have the data completely, but that is about for all the parameters, for every parameter, including lymphatic invasion, grade of the tumor, and grade 3 is about 40%. Now, going to the, this is what is in the article. A couple of things I did after that just to look at how it looks, and this is not in the article. And this is the receptor subgroups. I looked at the age versus age. We have 3,174 patients. And as you can see, 2029 are very small number, about 40 or so, and 80-89 is about 40 or 30. Just these two extreme ages, but they're there. But essentially, 30-39 are about 300 or so, and you can see that there is a triple negative is increased, 40-49, and as we come along, in fact, hormone positivity increases, and up to 70-79, we do have good numbers, at least in hundreds. And even at 60-69, where we have a good number, there's 64%. So the triple negativity comes down, in fact, much more than the hormone, the HER2 positive. And the receptor subgroups, I looked at by the tumor size, if it makes any difference. I'm not sure, I just looked at it playing around, and you all can think about it. Something came to thought. HER2 new positive, as we see, the numbers are not very high, and above 5 centimeter, very few patients and all. But when you get to triple negative, there seems to be somewhere some change as we go. This is below 1 centimeter and 1 to 2 centimeter and 2 to 3 centimeter and 3 to 5 centimeters and 5 centimeters. And here hormone positive is again comes down as the increase of the tumor size goes on. That is something to look at. And then we looked at these subgroups of the receptor subgroups with the lymph node status, pathological lymph nodes, and autoimmune positive is about 55-45. This red is negative, lymph node positive is blue, and we can see that the hormone positive seems to be equal, and the triple negative is quite 1 to almost 2/3, 1/3. That is maybe one of the reasons that seems to be doing well. And when we look at the lymph node P size and the lymph node status, again 3,264 patients, and below 1 centimeter is 68% is again small numbers we have. As I said, about 80 odd patients, but below between 1 and 2 centimeter we have over 600 patients, and there is lymph node negativity is high, and between 2 and 3 centimeters also it is high, and about 10% different. But above 3 centimeters, lymph node positivity increases, again 60%, which we would expect. Now, looking at the results again, coming back to the things here, this is the treatment profile, and the breast conserving surgery was done in 20% of patients, and the axillary sentinel node was coming up, this being from 8 to 14, now more, about 10%. And adjuvant chemotherapy drugs, there was no chemotherapy given to about 810, that's about 23% of patients. And anthracycline based about 20%, and anthracycline taxane combination based about 43%. So essentially, anthracycline is given about 64%, and the taxane alone are based rather no anthracycline is about 8.8, and others like CMR is about 3.7%. And we can look at the aromatase inhibitors was about 48%, and 44% got the tamoxifen. Very few we could see, or at least recorded, where there was a switch about 7%. And adjuvant radiotherapy, depending on that, and again, adjuvant radiotherapy by site, about 22%, 30% got both nodes and primary site, about 12% primary site alone, and 58% this thing. And in node positive, obviously the radiation was given to 60% of patients. And adjuvant trastuzumab was given to 260 patients received it, 46%, and about 54% didn't receive 302. And about 80 patients are missing here who did not have the details of any chemotherapy or the trastuzumab, so we don't have that. In these 562 patients, we have 300 did not receive and trastuzumab, 260 received the trastuzumab. And this is the survival data, and disease-free survival, and the 5-year overall survival. And if we look at the disease-free survival and overall survival, you can look at the tumor size. This is the reason I said to keep that in mind, less than 2 centimeters, which is essentially 1 to 2. There were 91% at 5 years disease-free survival, with the confidence intervals at around 5% upper and lower. And 2 to 3 centimeters is about 90.3%, and there was no difference between them when we looked at the univariate. And between 3 to 5 centimeters, it's 85.9, and more than 5 is 80.9. And overall survival, you can look at it, but somehow I do not feel this is significant. We can look at, because what we found, the follow-up, is most of the patients after a lapse, almost 70%, were not seen in the same institution after a month. So I think it's very difficult, at least in this population, we had that overall survival can be of any reliability. So it is disease-free survival really we can rely on, because only 90% our last follow-up at 5 years. And again, hormone positive, there was 91.6% and triple negative 85.5% and HER2 positive 81.3%. And again, we looked at node positive, node negative with it. And most importantly, I would like you to see this 2 centimeter thing, which is, I will come back to that, and less than 2 centimeters, positive lymph nodes 86.8%, and 2 to 3 centimeters lymph node positive is 87.5%, and the 3 to 5 centimeters it goes up. Similarly, node negative patients 92.5, 93.9. So they seem to be similar really in both of them. And the T1N0 receptor status we looked at, and the hormone positive T1N0 there is 97.5%, and the ERPR, the HER2 positive with T1N0, 68 patients were there, and 88.9, really 90%, and triple negative N0 T1 is 86.5%. But I think this is also, we have some data about patients who did not get the chemo and no chemo and no chemo in this, but that is not for this. And looking at the survival curves, the survival curves is like we can see this is the disease-free survival over 10 years, and as I said, at 5 years there was 19% last follow-up here, and there is an 88%. As you can see here, there is about 86.96%, 88% were DFS with a confidence intervals from almost 87 to 89.3. And median follow-up is 68 months for this disease-free survival. And this is the lymph node positive negative. Again, there is the difference as we can see. And this is the tumor size. The less than 2 centimeters is the red curve, and green curve is the 2 to 3 centimeters, and blue curve is the 3 to 5 centimeters. And again, we can see there is absolutely no difference between those two. And I'll come back to that. And the yes, this is the hormone receptor positive is the green, and the blue is the triple negative, and the red is the HER2 positive, which I am sure is partly related to the lymph nodes being higher than this, and also partly related to the more than half not getting the Herceptin, but trastuzumab. But I think we will analyze it much more later in the future. And this is about the premenopausal, postmenopausal. We did not find any difference between the two. And this is the multivariate analysis for the disease-free survival, and all these parameters in univariate were p-values were significant, and in the multivariate, PT size, which is a continuous variable in this, was significant. Tumor grade is significant. Lymph node status is significant, and chemotherapy drugs and the univariate chemotherapy drugs, primarily anthracycline, was the significance. And coming to the few background references we had, and what really made me look at the 2 and 3 centimeters, for example. And this is the paper by Dr. Paul Peter Rosen, a famous breast pathologist at Memorial, and Larry Norton, most of you will be knowing, again, famous breast oncologist at Memorial. They wrote this paper in '93, Journal of Clinical Oncology, and they looked at the size of the tumor. And they were also looking, this is T1N0N0, T2N0N0, 767 patients, and they were looking for the histologic thing and see whether chemotherapy can be avoided in these patients. But in the process, they also looked at the size And Dr. Rosen finally commented, this is the two curves here in the middle are the 1 to 2 centimeters, 2 to 3 centimeters. Top is 1 centimeter, less than 1 centimeter. Below is 3 to 5 centimeters. And he finally said that hence node-negative patients with tumor 5 centimeter or less in diameter can be stratified into low, intermediate, and high-risk groups with respect to recurrence on the basis of primary tumor size. These risk groups are not accurately defined in the existing TNM, suggesting that current designation of T1 and T2 disease should be reassessed at least with respect to node-negative patients. And as I said, we did not find even with the node-positive patients. And now coming to the tumor size in centimeters, again 3 to 6.9 centimeters. Below 1 is 3%, 1 to 2 is 18, 2 to 3 is 40, and between 3 to 4 is 22, and between 4 to 5 is 10 and 7 and 8. And cutting back to the 3 to 5 centimeters and 2 to 3, if we make, that's 40%. That means in reality, between 1 and 3 centimeters, we have 58%. And 32 centimeters, 32% are between 3 and 5, and this is 5 above. So 40% we have above 3 centimeters. This is important as we go. And this is the look at the 2008 to 14. Really, there is a variable, not much, about the same, and 5%. And if you come to this, really the 3 to 5 centimeters, this curve I made just to look at, show you, because in the subsequent reference about this New England Journal of Medicine paper, where the mammography, population-based mammography was looked at. And this is the, as you all, many of you have seen, this is the time the mammography was introduced in US, and there was a 30% increase in the incidence of invasive breast cancer, all invasive breast cancers. And then metastatic breast cancer has not been reduced. It is a different kettle of fish, and probably the cell is different and the nature of it is different. And when they looked at this from 75 to 2010, you can actually look at this. We can actually look at this from the here that the change was primarily from 5% of the TCS to 22%, and the 6% of 1 to say 1 less than 1 to 18%, 26 to 27% of 1 to 2 centimeters, and 26 to 15% of 2 to 3 centimeters. They also looked at 2 to 3 centimeters and not to 2 to 5 centimeters, and 3 to 5 centimeters from 25% to 11%, and 13% to 7%. And if we look at the, if we really take out the in situ and keep it at 5%, which is what ours, if we look at, and more than 5 centimeters from 13 to became 9%, and 3 to 5, 25 became 13%, 2 to 3 became 26 to 18% in this, and 1 to 2, 26 to 33, less than 1, 6 to 22. Because that means 3 to 5 is still a significant number, that is 22% in that mammographic screening as well. And the same thing if we look at the bottom curve that they have shown, again, here we can see the mammography at 2075 was 1975, and we can see that the 1 to 2 centimeters is the mostly diagnosed and in situ, and these are all increased initially and slowly came down as well, but this has come down to an extent, but that is what it is over time. And also interestingly, what was found is that in the same thing, what was found is that the larger tumors they called above 3 centimeters, 3 to 5 and 2 to 9, the treatment effect is different over 75 to 79 compared to 2000 to 2008. There is a better treatments available, adjuvant treatments. And the same thing here, so they concluded the chances of the people here in this group especially are dying of other things is much more. In here, 1 to 4 times, almost 4 in 1 chance of dying of something else in this, and 10 in 1 chance for dying something else from the breast cancer in this. And the 25-year follow-up from Canadian study, this was again an interesting study where the physical examination was put as a control as well, compared to along with the annual mammography, a major study. And I worked with Anthony Miller at that time. This was actually from 1980 to 85. And for them, the main outcome was deaths from breast cancer as the primary outcome. And when you look at this one, they could see that this is all-cause deaths from all-cause mortality. There is absolutely no difference. This is about 45,000 women in mammogram form and this, and about 4,700 deaths. And the breast cancer deaths is 505 and 500. There is absolutely no difference. So what they felt, our data show that annual mammography does not result in a reduction in breast cancer specific mortality for women aged 40 to 59 beyond that of physical examination alone or usual care in the community. The data suggests that the value of mammography screening should be reassessed, and the people in the MAPI arm had 3,250 cancers, breast cancers, and control arm at the end 133. 500 died in each from the breast. And this is the cluster randomized trial many of you are familiar with from Tata Memorial is ongoing. This is the interim the analysis at that time. And the schema was, as you all know, and this I understand that is being in the process of being published or the final results. And the screening of breast cancer with, again, Cochrane review, others' conclusions were, we believe that the time has come to reassess whether universal mammography screening should be recommended for any age group, defining declining rates of breast cancer mortality are mainly due to improved treatment and breast cancer awareness, and we are uncertain as to benefits of this screening mammography. Overdiagnosis has human costs and increases mastectomies and deaths. The chance that a woman will benefit from attending screening is small at best, and based on the randomized trials, 10 times smaller than the risk that they may experience serious harm in terms of overdiagnosis. This is from the Cochrane review. Now, looking at the GloboCan, as we all know that the Western world, it is about more than 100 or 110 per 100,000, whereas in India, as here, it is around 28 or so from what I understand, and in the cities probably around 32, 33 and 30, and in villages it is much less from Parshi, the registry we all know. Now, before summarizing summary, I just want to show one slide. And this is from the New England Journal of Medicine article I showed you. But in that, not in the main article, but the supplement, they had this curve. And what this says is that this is from the SEER database. And in 1975, the tumor size, they could not get in 37% of the patients was not recorded. And in this is the missing data of the tumor size, and in this is the mammographic study. And in 29% in 1982. From there, suddenly there was a rapid change, and 16% in 1983, missing tumor size, and 4% in 2012. So I think this is very important to me, because whenever we want to collect data, one of the things everybody says is that we will be missing this data, that this is not good and all. But we all should collect and look at it first. And then it will improve as we collect data and look at it, because we know we are missing documenting. So I think it's important to collect whatever comes and look at it. Over time, that will improve. Everywhere in the world, it happened the same way. Over decades, it didn't come overnight. And in summary, what we did, these are from the summary of the publication itself. That is, what we summarized is with a large percentage of the population still having tumors more than 3 centimeters, and the DFS being good for the tumors below 3 centimeters, and at least in our board, and the incidence of breast cancer being relatively less in our country as compared to the West, as we saw in the map, it is says that the population-based mammography screening is not advisable in India. I'm very strong about that, and it is more important to make the women and physicians aware of the importance of breast physical examination. Unfortunately, we have a problem of this inhibition, both for women and the physicians to get the breast examination, which is a major factor in the country. I think we have to shed that inhibition. And special emphasis is required to establish procedures to ensure timely follow-up of the patients. We had about, as I said, median follow-up 68 months, 19% only last follow-up, where we looked at. Now, as we prospectively look, I'm sure we can reduce it. And to collect, and for that, we only need somebody who can keep calling people. And in that last 19%, we lost 12% in the first year. And in first 6 months, we lost about 7%. So I think the first year is very crucial not to lose one. And to collect real-world data and look at the patient characteristics, treatment outcomes in depth, also take into account their socioeconomic state and demographic. I think it's very important for us, and I'm sure even for all the low middle income countries, for various reasons. And this is the map, and these are all the centers that we have presently installed, and some are using it more, some are less, some are yet to start. And the one in the blue are the one that collecting pooling all the data together. And thank you for patient listening, and any questions.
Thank you, Dr. Ramesh, for teasing into our own data and trying to. Jyoti?
Yeah, I have a question, sir. It was a very interesting data, and congratulations to all the contributing centers. And it will really set a benchmark for future studies in the country. Sir, I have one question that why in premenopausal versus postmenopausal population we did not find the difference. Generally, it is considered that premenopausal or younger women, they are having much more aggressive tumors. And the second one was, do we have some reasoning for why with regard to receptor status, like triple negative vis-a-vis others, they were also not having a difference? Your opinion, please.
Yeah, Jyoti, the postmenopausal, premenopausal, I must say we were also surprised strictly. I don't know whether the hormone, as we saw, hormone positivity is higher in the postmenopausal, definitely, beyond 50. That may be one of the reasons, and we have to look at that a little more. But we did do a table is in the article between the postmenopausal and premenopausal about the parameters. We did look at them, whether there was any difference between them. There is not a lot of difference, but I think probably the hormone positivity is one of them. I would think that could be, because when we looked at the hormone positivity, certainly with the age it clearly changed. And I think that is one of the reasons we have the better prognosis maybe in the postmenopausal. But then again, in the premenopausal, I don't know why, whether they took had more chemotherapy or what else. We have to look at that. I really could not tell you exactly. Yeah, but we did look at the parameters, and that was the table is. And the second question you had is about the triple negative. Again, the triple negative, interestingly, the lymph node positivity is much less compared to the other two groups, very clearly. And that I'm sure is the reason. They do reasonably well, and we know they are chemosensitive. And as long as they take the chemo, I think they do well.
Any other questions from anybody, please? Any other questions, please? Otherwise, we move on to the next topic. And I think today, no conference goes without. Hello, Sekhar. Dr. Sekhar, how are you?
Fine, sir. Good evening. Just came back from the hospital.
Okay. Thank you. I think we had the session from Dr. Ramesh. I think you must have heard the.
I heard. It was a really good discussion he had. Thank you so much, sir.
Okay. So next person is Dr. Govind Babu, who will be talking to us, who will be moderating a panel discussion on nothing else but treating breast cancer at the times of COVID. Dr. Govind Babu is retired professor and head of medical oncology at Hidayat Institute of Oncology, and now is a freelancer at SCG at Bangalore. So Dr. Govind Babu, please.
Thank you so much, Dr. Doval. Can I have my slides, please?
Yes, please.
Okay, I think I have. Okay.
Come in.
Right. I'll work the slides from my end.
Yes, sir.
Okay. Thank you, Dr. Doval, for getting me on this panel. I think we had two very nice lectures. So let's look at panel discussion. I have a couple of cases. And to invite my panelists, Dr. Ajay Bapna from Jaipur, Dr. Jyoti Bajpai from TMS Mumbai, Dr. N.K. Warrior, Dr. Sevanti, Dr. Nitesh, Dr. Somshekhar, Dr. Sudeep Gupta, and Dr. Devinder Paul. I'm not too sure how many of them are here, but let's get started. I was under the impression that the two lectures which were supposed to be there on the guidelines would cover some of the guidelines that have been incorporated after the COVID pandemic has come in. So I had taken out those slides. Anyway, we will discuss those. So let's look at how we manage breast cancer today in these COVID times. So I'll start with the first case. Can everybody hear me? Okay. So this is a 46-year-old banker who is pretty active otherwise, premenopausal, no comorbidities. She has a very positive attitude to struggle with the disease. I think this is an important aspect that we need to keep in mind when we treat our patients. And she is willing to undergo the most effective treatment to get the strongest control of her disease. So the clinical staging is T2N1M0. Clinical, I mean even the imaging. She has had a true cut biopsy, and the histopathology report is IDC grade 3, ER 7%, staining level PR negative, HER2 negative. So let me straight away go to Dr. Somshekhar and ask him what is the type of surgery that you would do to this particular patient given these clinical characteristics. Somshekhar, can you hear me? Hello? Can you unmute Somshekhar, please?
कर रहे हैं चलो मैं काम करो अभी इधर बता रहा आवाज आती है
Hello? Dr. Somshekhar? Hello? Dr. Som?
I think Dr.
Can you hear me? Okay. You want the previous slide? Can you hear me? NK, can you hear me? Hello? Hello. 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 Warrior, can you hear me?
Yeah, I can hear you very well.
Okay,
Yeah.
I don't know if Soundseeker is on the line or not. So,
Yeah, I think you can proceed further.
yeah, okay. Since he's not there, I'll go ahead.
Yeah.
I think he's the only surgeon on the panel, so we will not be able to have his wisdom. Okay.
Yeah.
So this patient underwent lumpectomy with axillary dissection for the right breast. She had 5 ipsilateral axillary lymph nodes out of the 12 that were removed, and the tumor is high grade, like I mentioned, and it's 4.1 centimeters in maximum diameter. Okay, now that NK is on the line, what would you do next to this lady?
Yeah, so the looks like a T2 N2 lesion, right? T2 N2.
Yeah, that's right.
Yeah. So next step is definitely to ask for the IS4, which we routinely do in our center,
Okay.
and yeah, depending upon that, we will decide further.
So you do a KI67, is it?
Yeah, certainly.
Okay. Okay. This lady's KI67 was 24%. So she got adjuvant therapy of TAC6. She had radiotherapy followed by tamoxifen. She also had breast reconstruction. Would you like to comment on the adjuvant therapy that this lady got?
To me?
Yes, sure.
Yeah. Okay. So this patient has received a fairly aggressive regimen with the use taxane as well as anthracycline. And,
Right.
Yeah. I feel currently we don't generally follow this TAC regimen because of the toxicities involved, and but so being a T2 and 2 lesion, it is fairly justified.
Okay.
Right.
Okay. Dr. Jyoti, suppose this patient was seen by you this week at Tata Hospital when the COVID pandemic is going on. What would you do?
So, sir, I would have preferred the sequential regimen rather than concomitant taxane and anthracyclines. I would have preferred AC followed by taxane. Also, I would have given prophylactic growth factor support because I don't want really.
That is of course done.
Yeah. For all the cycles, even EC, which otherwise I would have not chosen, but because of the COVID pandemic, I want to use liberal growth factors. That's what would have been my choice.
Okay, so I think now the treatment decision is going to be AC versus BC after COVID, before COVID.
Absolutely, sir.
Dr. Babu, can I interject the question?
Yes.
Dr. Nitesh.
I was just going to ask you next. Yeah, go ahead, Nitesh.
So I missed maybe initial slides, but why didn't we consider neoadjuvant therapy? This is not triple negative patient.
Yeah.
So she was triple negative, node positive. So that was an option also. I'm not saying that.
Correct. Yeah.
Okay. Thank you.
That's fine. Yeah. Anybody else had any different thoughts on this? Dr. Sevanti?
So I'll go with Jyoti, where I think is what I would consider.
So would your treatment change if it was AC versus BC? Before corona, after corona?
So for high risk patients, I have not I've not had to change switch of therapy.
Okay.
And this patient was young without any significant comorbidities.
Okay.
One definitely has to keep that in mind when you're choosing.
Absolutely. Yeah. Dr. Sudeep?
Yes, Dr. Babu, I'm very much here.
Yeah, can we have your inputs on what's happened so far?
So I think I agree with all the things that have been said by my very wise colleagues, and I go with that.
Okay, thanks, Sudeep.
Even in the pre-COVID era, I was not a great fan of so the situation for me is reasonably straightforward.
Okay, thank you. So this patient actually was on follow-up. Unfortunately, 10 months after the adjuvant end of radiotherapy, she came with recurrence and she had disease in the liver and bones. So what would you do at this point of time? And if you're looking at metastatic disease, what are the factors that determine the aggressiveness of a disease? So I'm sure all of us will call this patient to have an aggressive disease. Yes? Or anybody begs to differ?
Yep. The high lymph node positivity is definitely a factor. Yeah.
Okay.
So I would have liked to do a liver biopsy and then retest ERPR, but also I would like to androgen receptor on this patient.
Okay.
And so more than 6 out, so I guess PDL1 will be a question as well.
Yeah. This was a little about 4 or 5 years ago, so we were not doing all those things. Anyway, that's fine. So this was the time when we were actively using taxanes. We didn't have too much of data on the use of immunotherapy in these patients. So at this point of time, we had a concept that there is something called virulent metastatic breast cancer. So do you believe that this was virulent? And this is just some data that I took out saying, when do you call a metastatic breast cancer aggressive? So this includes the TNM stage and specific associated metastasis like visceral versus bone or multiple mets or the burden of metastasis and the biologic factors. This, as Nitesh was telling, it's more akin to a triple negative disease, and the Ki-67, which Dr. NK was mentioning, and the clinical assessments, talking of the response to prior therapies, how long is the disease-free interval, how rapid is the progression of metastasis, the performance status, and the age maybe. And additional genetic factors, which probably are here today, we would be doing BRCA1, TP, probably the PDL1. Would you like to add anything else on this, Nitesh?
So as I said, androgen receptor.
Okay. How commonly are you doing it in your practice today?
So now I feel we should do it in all triple negatives, but if we are really seeing a benefit is where there is a triple negative, very slow, non-aggressive kind of recurrence pattern, very opposite of what you've shown on this patient. But having said that, I think we should do it in all patients and see if it becomes a treatment option at some time.
Yeah, right now in our institution, they're routinely doing it. In the last look at data was about 3.5%. So, of course, it's a small cohort still. So this is just to show you the disease presentation and overall survival. And we know today that if there's a lot of visceral disease, if it is the number of metastatic sites, then this can sort of predict the overall survival. If the metastatic site is just one, the median overall survival is 31.3 months, 2 sites 24.5 months, and 3 or more sites it's about 19 months. So of course this is pretty old data, but I think the principle holds the same, that the high number of metastatic disease, the shorter is the survival. We know how this lady presented. So do you believe at this that this was a high risk presentation or low risk? I think Nitesh already said that it was triple negative, so you are grouping it under a high risk. Any other thoughts, Dr. Sevanti?
I would also call this high risk, sir, and the discussion about adjuvant was
right.
And I mean, she demonstrated very quickly
that
the disease was aggressive.
Correct. Jyoti, any thoughts on this?
Yes, sir, I agree. I agree with the house here. It is an aggressive disease. Pace of the disease is high.
Yeah. So the size was approaching 5 centimeters. That local recurrence, lymph node number high, and the receptor status, like Nita said, it was almost triple negative. So this is just to show you the 5-year survival as a function of the number of positive axillary lymph nodes. So as you can see here, as it increases from 0 nodes to more than 20, the 5-year survival dramatically drops from being about 80% to less than 10%. So I think positive nodes is one of the very important prognostic factors for survival for us. Dr. Sudeep, your thoughts on this paper, and do you have any data from your series?
So I think this data is what we all have experienced in our clinical practice as well. That positive lymph node positivity, the lymph node burden, as well as tumor size are the most important prognostic factors of breast cancer. And I often use this kind of data to think about many different decisions, including, for example, extended adjuvant hormonal therapy, etc.
Yeah, I do the same thing for prolonged hormonal therapy. Excellent. So, Dr. Devinder Paul, are you there?
Yes, sir. Good evening. I am here.
Okay. What are your thoughts on this?
So I agree with the house that this lady has a very aggressive course within the span of 9 to 10 months after receiving a full course of anthracycline and taxane. She has progressed in that too in a multiple sites. She requires systemic treatment, but in the COVID era, after discussing with the patient about his intent of treatment and palliation only, I think starting around the oral chemotherapy will be a prudent idea. And in the meantime, we can send the
slowly. Yeah. Dr. Devinder, can you tell me where you practice in Ludhiana, because I don't have the details with me?
Sir, I'm a pastor from the DM from the Tata Memorial Hospital. So I'm a student of Dr. Sudeep, and I'm in Dayanand Medical College at Ludhiana.
Okay, so a lot of TMH genetic pool here. Okay. So in hindsight, treatment would be any different in the pandemic time? I think most of you have answered this. How would you differently treat? So I think that is okay. So your next step in this patient. So what would you do if she had come today with this disease? Nitesh?
So after the
AR negative.
Triple negative.
AR negative. Yeah.
Triple negative. So she's less than a year after failing taxane. I mean, technically you can re-challenge with taxanes again, either as eribulin or as Abraxane. But I would prefer gem and platinum in this patient because I think she's very close to her failing taxane.
Right. So this is what we have: chemotherapy for metastatic recurrent cancer, and you can look at the preferred agents, combinations, and the others. So Nitesh, you're going with the others group, so that is fine. Jyoti?
So my choice would be either eribulin or gem carbo both. I want to look for how fastly she's her tumor doubling. In fact, so if she's very symptomatic and very fastly doubling, then I would prefer a doublet like gem carbo or otherwise eribulin.
Okay.
Govind, can I interrupt?
Yes, please. Go ahead. Oh, sorry, Ajay.
Yeah, I'm here.
I didn't see your picture, so I forgot. Yeah. Sorry. Go ahead, Ajay.
So gem carbo again because the topic of discussion today is the COVID time.
Absolutely.
If you start the gem carbo, then patient has to come every day 1 and day 8.
Yes.
So that is not desirable during the pandemic. So we need to plan a chemotherapy where the patient can be called after every 3 weeks or so. So gem carbo commuting will be very difficult for the patient.
Yeah, in fact, Ajay, I agree with you because we are right now running a clinical trial, and that patient is on the gem carbo arm. This study started before the pandemic, so we are finding it so difficult to get her every week, but we are managing it. Fortunately, she stays close by to the hospital, but I understand because with all these lockdowns.
Dr. Babu,
Dr.
Babu, if suppose a patient is asymptomatic and is healthy and doing well, should we start treatment right now, or it can be delayed for some time? Anyway, we are dealing with a metastatic aggressive disease.
Right.
So
Yeah,
Yeah.
and fortunately, I have the right to not answer your question, so I'll ask the other panelists.
So I think because the disease is aggressive and fastly growing, then already it's metastasized to liver and other organs. So I
Yes.
think if you will wait further, then perhaps we will lose the window. Right now, it is a thin balance between COVID and cancer, and because the pace of the cancer is looking high, perhaps in this young, well-fit patient, I would like to go with chemotherapy now.
Absolutely.
Right.
So, in fact, after this COVID pandemic has come in, we are fighting with two C's. Earlier, only one C was cancer. Now the second C has come in. So it is a compounding effect that is happening. Yeah, that's right. So this is the today's breast cancer algorithm. So we have already discussed what she was on, how long the disease-free interval was, and you have several options looking at how old she is, what are the comorbidities, and several other things. So this patient, again back to a patient, she received capecitabine and bevacizumab. Those were the days when bevacizumab was really, in the picture, because there were a lot of trials then saying that there is a lot of benefit with that. So she was started on bevacizumab. She had stable disease for 3 months of treatment. She got another additional 3 cycles, but she progressed. So she had stable bone disease, but she developed new liver metastasis. Nitish, what would you do now?
So now we have to see of what she had now. We are still left with gem carbo, intradental.
Do you want to repeat a liver biopsy at this point of time?
So if you haven't done then, I would repeat now. If
No,
you
it was done. It was done. It was done at that time.
I don't see the benefit of doing it.
Yeah. So it is just about 8-9 months. So I don't think it would have changed much in the short period of time. Yeah, that's right.
So in the COVID times, we are actually planning our treatment as per the priority of the case.
Yeah, absolutely.
So initially also the ESMO and NCCN, she was falling into the B3 category, priority for me.
Correct.
So I would like to treat this patient only by being the first line treatment for metastatic breast cancer, but not for the second line metastatic breast cancer treatment.
Right.
I would just put her on the supportive care rather than again offering her any kind of systemic anti-cancer treatment.
Yeah, Ajay, I got this patient precisely because she was treated in the pre-COVID era. And so we have all the data. So I was just putting it across so that how would we treat her differently now?
Yeah, not second line of COVID era.
Yeah. I also think it's the same way. I do agree with Dr. Ajay.
Yeah. But do you think that you should make the decision or you should let the patient take the decision of what you make?
Definitely the decision is the decision should come from the patient, but we can always tell them, advise them regarding the risk of getting
exactly. Yeah.
Sir,
can I make a comment? Sir, can I make
yes,
please.
So I in this young patient who's only 47, and you said that she was highly motivated and wants to go do best.
Correct.
I think I will really discuss this with patient and
family.
Absolutely. With the risk involved, and I will still prefer to start with metronomic chemotherapy at least one.
Okay. So I think this aspect of participatory medicine is much more relevant today because we need to really discuss all the pros and cons and then take a final decision. So this lady has a taxane-free interval of 17 months. So do you think we can re-challenge this patient with a taxane?
Sir,
she had an unsatisfactory result with first-line capecitabine. So Jyoti, I don't know if capecitabine again would help her.
So again, sir, I think if there is no financial concern, I would like to go for eribulin here. If she can, and also I would like to consider how is the peripheral neuropathy for considering both either eribulin or taxane. Otherwise, both are the valid choices, I would say.
Yeah, she has grade 1 toxicity, and today we have generic eribulin as well. So that is the other advantage we have today.
Correct. So both of these drugs are weekly paclitaxel, but weekly again with the logistic constraints. Otherwise, with toxicity profile is better. So eribulin or pacli would be my choice.
Okay. So what was her androgen receptor positivity going?
It was not done that time.
So
I told you, this was pretty
so
old.
In second line, actually, we will always prefer in COVID time an oral medication.
But how much of data do we have on treating the AR receptor with the AR blockade?
So instead of offering with a very limited data about the other IV chemotherapy, so this can be explained to the patient and let her choose if she can be put on some kind of oral treatment rather than again parenteral.
Okay.
Go ahead, Jyoti. So the oral metronomic chemotherapy, as I said, may be one of the options.
Yes,
and,
yes,
of course.
Now second line is parenteral at least.
But we cannot completely rule it out. I understand the concerns here, but we cannot completely rule it out. And especially it is an aggressive disease, and metronomic takes time. And when the disease burden is high, then again the working of metronomic is also little of concern. So we also should consider all these factors and then choose. So again, those parenterals are also kind of options.
Yeah. Right.
Sir, I feel this has become very challenging and confusing actually, sir. I've always lived with the thought that no matter what, the oncology treatment comes and then other aspects. There may be cost, there may be logistics, and now there's COVID.
Yeah.
And I feel that we may be now changing decisions based on COVID before oncological treatment.
That is true.
I'm genuinely getting confused that if I am expecting a patient is going to do badly from cancer, which is a certainty, versus I have a smallish % chance that they will die of COVID if they get exposed to outside their home, which is a priority in this patient. I find this challenging as a question.
Absolutely. Like you said, as if we didn't have enough things confounding, we have COVID as well now. That's true. I agree with you. Yeah.
Do anybody use liposomal doxorubicin?
Yes, yes.
Govind Babu?
Yes, I've used.
Liposomal?
Yeah, yes, that is one of the options, of course.
So I have a point to make, sir.
Yeah, go ahead, Simon.
My thought here is that this is a young woman.
Yes.
The disease. I would go all out, COVID or non-COVID. And
okay.
At this juncture, if we didn't biopsy earlier, I would want to biopsy now. I would sequence the patient. I would try and understand the biology again. The key 67 that you showed was 12%.
Yes.
And that makes me wonder what are we dealing with exactly? So I would re-question all of that.
Okay.
Then design my therapy. I would go with eribulin at this time point.
All right.
Patient had issues.
Okay. So at this point of time, when this patient was treated, we didn't have the luxury of eribulin. So we discussed the taxane re-challenge for her. So I thought I brought this case because this was before the COVID era and thought we will see how she was treated and how she can be treated now. So is there an evidence for challenging taxanes and re-challenging taxanes in metastatic breast cancer? So this is the data that we had at that point of time. If it is within 1 year, it is about 35%, 1 to 2 years, about 43%, and if it is more than 3 years, it's about 64%. So that was the data there. And of course, like I told you, this patient came in when nab-paclitaxel had just come in. So we started, and we had this data, so we started this patient. And you must be wondering why I put this picture. So if you see this elderly gentleman in front, I mentioned elderly gentleman in front because I'm behind. So this person is Dr. Vani. He's the one who actually worked on paclitaxel. So I was lucky to meet him. And this is Dr. Neil Desai, who worked on Abraxane. So I was fortunate to meet both of them under the same roof. So I thought I shouldn't miss the opportunity of taking a picture with them. So I thought I'll share this with you.
Very nice.
Thank you. So that is case 1. Hopefully, with what I've shown, we will try and do something different. So this is a second case who is a triple positive, 58-year-old, locally advanced breast cancer and no comorbidities. This is the PET scan of this patient done in December of 2019. And what I want you to look at is the burden that is here. So she has no disease elsewhere in the body. So how will you treat her? Som? Is Dr. Somshekhar there now?
Yeah, Babu, yeah.
Sorry, we missed you in the first case, and we did. We did a lumpectomy and axillary lymph node dissection without.
I saw that. I could see it on the screen. I could see the whole discussion on the screen. I couldn't chip in.
Oh, okay. Okay. So I think I'll use your expertise here.
Yeah, no problem. See, whether COVID or no COVID, I will just little transgress to that and come back to this case.
Yes, please.
As a medical oncologist, you are quite a more liberal because your interaction, unlike surgeon and vapors, are very less. Second thing is because we need to see at this moment if we operate and a patient is asymptomatic but post-op convalescent they turn out to be COVID positive, then they have 30 to 40% mortality than other people.
And she will sue you because you gave her COVID in the hospital.
Exactly. So we have a special concern. So, but the beauty is there are 3 guidelines which has come: the BASO guidelines and the SFO and IASO for breast cancer. Where only patient we would operate would be a T1N0 N0 who is not a candidate for neoadjuvant hormone therapy.
Okay.
Rest all we would send them to medical oncologists. They maintain more hygiene and more protocol than surgeon, so they take the burden of COVID.
Now, thank you so much for giving us such status.
So if you see in the breast for surgeon and the imaging specialist category 1, 2, 3. Category 1 is a suspicious lump, immediate evaluation and diagnosis, core and IHC, very important.
Right.
To risk stratify so that if they are ER negative, HER2 positive, all of them actually go to medical onco for chemo. If they are ER positive and if they are not T1 N0, then again they go for neoadjuvant treatment. Very few, the only patient which are supposed to operate is somebody who has completed all neoadjuvant treatment and they're waiting in window of surgery are the only one we operate.
Okay.
Now this case you have put is very simple and easy because it's a locally advanced breast cancer. So we would assess a triple assessment, clinical evaluation, and then core biopsy, do ER, PR, HER2 67.
Well, that is done. I
And
told you.
metastatic
She's
survey would go to you.
Yeah. So she has no metastasis. Okay. So
What is the ER, PR, HER2 status?
All positive. Triple positive.
Good. So either way, all LABC would go to neoadjuvant unless they are luminal A, they would go for neoadjuvant chemo with anti-HER2 therapy.
Okay. So this is a guideline for who should be considered for preoperative systemic therapy for early breast cancer. Of course, this is locally advanced. And would you treat her today with dual HER2 blockade plus chemotherapy, Sevanti?
So there is data, but I haven't, necessarily made it a compulsion to treat every patient, and there are many who are not able to afford a dual.
No, we are not talking about affordability here.
So there is enough data today to give dual HER2 blockade in your and yes, I would offer it to the patient.
Okay. Nitesh, what would you
Yes,
do?
I would, sir.
Jyoti?
I may just start with trastuzumab along with paclitaxel and see how she's doing. Many of the patients.
No, May. What would you do for this patient?
I will do this. I mean.
Okay.
I will start with single agent and say trastuzumab along with taxane, and we'll see how she's doing. Many patients, when we are giving single agent, also they are doing well. So I will not start with dual.
They will do well with single agent also, but would you do dual
right now? So that's why I'm saying
so you will not do. Okay. NK, what would you do?
Yeah, given a choice, I will definitely go for dual HER2.
Yeah, you're given a choice.
And yeah, in a couple of patients, we got excellent response and pathological CR with the.
No, like I showed you, this patient came in December 2019. Okay. Right, Ajay, what would you do?
I would use dual HER2 blockade with docetaxel and carboplatin combining with pertuzumab and the trastuzumab.
Oh, okay. Dr. Devendra, would you differ? In Ludhiana, would you do the same as you do in match?
No, sir. I'll go with the same, but the only thing is that she's HER2, but she's triple positive. The data per se is more in favor of the patients who are only HER2 positive and ER negative, but still, her dual blockade is the one.
Okay. Okay, thank you. So this is the data that we have, Newsphere. This patient got 3 cycles of THP, and in spite of growth factors, she developed 1 episode of febrile neutropenia, and she had grade 2 peripheral neuropathy at the end of 3 cycles. So what would you do at this point of time? Ajay? She's finished 3 cycles. She's had good response clinically.
So, now the febrile neutropenia.
Yeah. No, she has recovered. But I told you that she developed it, but she's okay.
We complete at least, giving this chemotherapy for at least 3 months, and then can we discussed in the multidisciplinary team whether she can be operated upon or not.
Yeah, you're my part of MDT now.
Yeah. So after 3 cycles, we need to assess her for the response.
So this is her PET scan.
Yeah.
So this is the disease I showed you, and this is what it is now. Okay.
Yeah.
Good. So Somshekhar, what would you do now?
In case of triple negative and HER2 positive.
No, this patient.
She is triple
That's
positive.
what. So this patient is HER2 positive. In HER2 positive, if I opted for neoadjuvant treatment and they're responding, they're not those 3 to 4% rare progressive. I would complete the entire neoadjuvant treatment, and then I would reassess the patient.
Dr. Somshekhar, the neoadjuvant will continue for then 1 year.
No, but patient has not completed all the chemo, right?
But if I have to continue this anti-HER2 blockade,
And also patient develops
has all the neoadjuvant chemo be completed? Has all neoadjuvant chemo
He
completed?
has finished 3 cycles.
So that's what. So it has not completed all the chemo.
So how many you want to give? How many you want to give?
See, what is the reason you opted for here?
chemo is for 1 year.
We can't because the fitness already now
Yes.
is great for so it's not wise to continue chemo.
This is a case of LABC, and you are given 3 chemo, and you are given a dual HER2 blockade.
Yes.
So the ideal is, I think, till the maximal response, and then go for surgery, and rest of the treatment can be given post operatively.
No, but in HER2 positive and triple negative, both options are available. Either a complete all chemo you complete and keep only anti-HER2 therapy, then you operate.
So surgery will be done after 1 year.
Surgery will be done after all the chemo is completed.
I asked for the
Dr. Sudeep, can I get you one?
He has left.
Oh, he has left. Okay. Seventy.
So I was just saying, as per the Christine study, it's just 6 cycles of chemotherapy with the full HER2 blockade.
Yeah.
The patient has already received 6 cycles. There's been febrile neutropenia. The patient responded really well.
Yeah.
I mean, this is not standard of care, but one would want to consider surgery at this time.
Yeah. So let me give a little more background of this patient. Her daughter is a physician who is taking care of COVID patients in Dubai right now. Okay, and fortunately she has not had contact, she has not come in, or this lady has not gone there. So she is
Can I ask a question, please, sir?
Yeah, go ahead.
So questions, sir. So the right upper lobe of this patient seems to have a met there. So I don't know if this was a oligometastatic HER2 positive which changes everything, or whether it was just LABC, sir.
Yeah, it was just LABC. We discussed with the radiologist, and he felt it was a non-specific
So
thing.
the second thing is, I think it's actually a surgical process. She is operable, operate. If not, we still have anthracycline we can give without neuropathy.
Nitesh, surgeon wants you to give chemotherapy. You want to do surgery.
So I think we need.
Anyway, let me tell you what we did.
Everything is reversed. In COVID, everything is reversed.
If you look at Babu, if you look at the guideline from SSO, ASO and IASO, HER2 positive patients who are responding and part of neoadjuvant surgery should be delayed as much as 6 months. You are not even into 3.5 months of treatment to this.
Yes, but I also showed you that she had problems with the therapy. So we need to keep that also.
I think we have to individualize the patients and then do it.
Absolutely, Dovell. I was just coming to you for your wisdom.
If she is responding well, I think we will continue up to 6 cycles.
Yeah.
But if there is a lot of morbidity, then I think better you can intervene.
In fact, she came with febrile neutropenia. She had candidiasis, so fortunately she came out of all that.
Yes.
So my son,
Govind, this is Ramesh.
Yes, Ramesh.
Would you give these people anthracycline at any point?
See, there is actually a study called TRAIN, which has actually combined anthracycline with HER2 blockade, and they have not shown worsening of the cardiac events. So that is one study. In fact, there are 2 studies which have shown So yes, that is also
The
possible.
reason I brought that up really is this debate about when do we do surgery or what do we do.
Yeah.
Especially when you're giving a dual blockade, what I understand is that you do 4 cycles.
Yeah.
Finished your the dual blockade, the TAC-10, and then do surgery and then give your anthracycline and go back to it, because anthracycline is a good outdoor responsive drug.
Correct.
We cannot, so far at least, people have not completely given up on that.
No, with dual HER2 blockade, there is evidence that you don't really need to use anthracycline also. You can use taxane and carboplatin and not necessarily add anthracycline.
Yeah, but that has not come yet.
It is not a part of the thing that you need to use anthracycline with dual HER2 blockade.
Dr. Ramesh Nimegadda is right in some way, because the level of evidence for dual blockade versus sequential AC followed by paclitaxel or trastuzumab, the level of evidence is same. So no one regime is better than the other.
Trifinat study.
So there is no category 1 recommendation in this patient. All are 2A.
Yeah, correct. So whatever you are comfortable with.
So Dr. Ramesh.
So I think if we would have started with my choice, the single, perhaps we would not be having febrile neutropenia, and perhaps the discussion was in different direction.
Unfortunately, this was the decision we took, Jyoti.
Yeah, sir.
Okay. Yeah. So this patient, she underwent BCS plus sentinel lymph node, and she had complete pathological response. Breast and axilla, of course, that is when we call complete pathological response. I don't think we have a radiotherapist here, right? So what would you do for the next cycle? Ajay? She has finished 3 cycles.
We'll continue the trastuzumab now to complete the 12 months of the trastuzumab. Pertuzumab, there is no data in the post-operative setting. So continue the trastuzumab.
No, that is data for dual blockade as adjuvant also. No, now what I'm talking is she has finished 3 cycles of chemo plus dual HER2 blockade. Would you like to continue chemotherapy?
Yeah, 3 more cycles. 3 more cycles of chemo plus dual N2 HER2 blockade, and then continue the trastuzumab. I'm not sure about the maintenance pertuzumab. If anybody can.
I'll show you some data on that.
Yeah, sure.
Nitesh, what would you do?
Sir, I would certainly give 12 months of Herceptin.
No. That is later on. Now she's finished. Yeah.
Sir, very debatable actually. I personally don't think I would want to give her more chemotherapy. Okay. I don't see the adjuvant benefit in a pathological CR. Okay. But she is incomplete on her chemotherapy, so I can understand somebody accepting.
Yeah. So, what I did, I'll tell you. I had a discussion with her, and I thought that she must get 1 more cycle of chemotherapy. So I substituted docetaxel and carboplat with eribulin. And I was expecting she could tolerate it well. But unfortunately, she came down with a febrile neutropenia again.
Oh.
Yeah. So fortunately, we got her out, and then she said, "I will not take any more chemotherapy." So I also decided I will.
Dr. Babu, why do you want to give further chemo? If at all you want to give chemo,
no, because I thought she had.
The capecitabine would have been a better choice.
Correct. So anything would have been a better choice in hindsight. So I thought eribulin was pretty safe because I have had good experience with eribulin. So, but she did develop. So we stopped after 1 cycle of eribulin with dual HER2 blockade, and I don't think the radiotherapists are there. She also got radiation, and now actually because of all these problems, I'm giving her dual HER2 blockade, but I've shifted from chemo to anastrozole. So this is the proposed strategy. I think somebody was talking about dual HER2 blockade as adjuvant. So here,
I was.
Yeah. So here it is for 1 year. Either Herceptin alone, trastuzumab, or trastuzumab plus pertuzumab for 1 year. And if there is a residual disease, then of course TDM. So are all of us following this algorithm that is put up here? This is actually from clinical care options.
So it is with or without pertuzumab? So what
with
was
pertuzumab.
No, this is with or without?
Yeah, both are okay.
So is there any graph, Kaplan-Meier, you can show the addition?
I don't have that, but I'll send you the details.
Whether it is really benefited?
Yes. I'll send you the details. I don't have it here. So that is how I manage this lady. Yeah. Dovell, your final thought on this case? Dr. Dovell? Okay, he's unmuted. Okay, so let's rapidly go on to the third case. I think we're running out of time. This is a 35-year-old lady who has metastatic breast cancer, mets to bone, lungs, and liver. She's ERPR positive, HER2 negative. Her symptoms are mild cough, abdominal pain. Her basic evaluation of the biochemistry and cardia are normal. So how will you manage? Let me start with Ajay again.
So she is a young female with symptomatic metastasis.
Correct.
And what were we can put her into the visceral crisis because she is quite symptomatic for the metastasis.
Okay.
So for a very quick response, she need to be started on chemotherapy first. Because she is not a right candidate for hormone therapy plus CDK4/6 inhibitors.
Why do you say that?
She is symptomatic for her metastasis.
Okay.
Because
Jyoti? Dr. Sevanti?
So yes, she is symptomatic.
Yeah.
But, I didn't get the message that she was, overtly symptomatic. And the other message that came through was that all her labs are good.
Yes, that's right.
So I would actually want to try inhibition.
Dr. Devinder, what would you do?
No, so I would explain to
go ahead, Sevanti. Finish.
I would just explain to the patient that there's this borderline situation that we are managing, but I would like to give a try to CDK4/6 inhibition.
Okay. Dr. Devinder?
Yes, sir. Again, I'll discuss with the patient how much fast he wants the response. Of course, CDK4 inhibitor is one option, but if the patient is quite symptomatic, then giving chemotherapy is also one of the options.
Okay.
So we don't know actually the magnitude of symptoms. So
I told you, she had mild cough and mild pain.
Yes. So in that case, we can just continue with CDK4 and the hormones.
So I have just put this algorithm here, which was actually from Dr. Hotobayagi, and this was first published in 1995 and again in 1998. So for a long time, we have been following this. I'm sure most of us have been following this at least, isn't it? Yeah. Okay. So this is just to tell you that we have characteristics in the pre versus postmenopausal women. And we all believe that younger women have aggressive disease because of various factors, and also they tend to have poorer outcomes. Sudeep, can I ask you your opinion on this? Oh, he has left, sorry. Okay. Dr. Dovell? Dovell also has left. Our host has ditched us.
No, those are like mine might have not able to unmute.
Okay. Dr. Nitish? Okay, let's ask the surgeon himself now. Somshekhar?
I agree. This is what was a belief, but not necessarily now. Things are a little bit changing. We need to individualize.
Okay. So we have this class of drugs, the cyclin 4/6 inhibitors, and we have 3 of them. In fact, there's a 4th one, which is an intravenous one, which is just coming. So we have data from endocrine therapy in premenopausal patients. This is actually all the combinations and the Oxford opinion with level of evidence and grade of evidence, and also the AGO. So you can see that all of them have actually included CDK4/6 inhibitors in premenopausal women. And I have been involved in both ribociclib and abemaciclib in the premenopausal women. So I think our concept that hormone therapy is slow and chemotherapy acts rapidly needs to be challenged. And many of the guidelines are now actually putting up these hormone therapies with CDK4/6 inhibitors as a first line. In fact, there is data from the arithmetic study which has actually done a drop in Ki-67 at 14 days after giving aromatase. And the drop has been almost 50%. So we all believe Ki-67 is a proliferative index. So within 14 days, if there is a drop by 50%, I think that is good response. So I think the concept that has settled in our brains need to change as well. And with the addition of CDK4/6 inhibitors with the aromatase inhibitors and ovarian function suppression, I'm sure they will be doing better. And this I have actually seen in the patients who have been on both these trials. Have anybody else been involved in this clinical trials of these two CDK4/6 inhibitors?
Not really.
Okay.
So what will be the your choice of CDK4/6 inhibitor amongst all these three? Because there is a very good data of abemaciclib now, particularly in this case.
Yes.
Because she has high-grade tumor, liver metastasis.
Yes.
And
so there is there is data comparing all the three CDK4/6 inhibitors. Of course, there is no head-to-head comparison, but there is preclinical data to show that the ribocyclic activity of CDK4/6 inhibition is better, and abemaciclib has more of CDK6 inhibition, and the toxicity profile is different. Palbociclib has been there for a long time, so we feel comfortable with palbociclib because that our hands-on experience is for a much longer period with that. But I have a personal bias with ribociclib because I had one of the largest series on the study, and that's published in Lancet Oncology. I happen to be one of the authors. Abemaciclib also we have been involved in the study, but the side effect profile is slightly not as good as with ribociclib, especially the GI toxicity.
But the only point is during the COVID time, if we are discussing, probably offering her ribociclib is little bit, questionable.
Palbo would be a better option.
Why do you say that?
Because you are more used to it, actually.
Correct. No, the other thing, no, I was trying to ask Ajay why he doesn't want to use ribociclib instead of
Suppose, unfortunately, if she develops some COVID infection, then she will have to be given either azithromycin or the hydroxychloroquine, which further prolongs the QTC prolongation.
Okay, good you brought that up. The QT prolongation of ribociclib is when it was used with tamoxifen. So the study had a choice of using either tamoxifen or a non-steroidal aromatase inhibitor. So it was with tamoxifen specifically. So most of us are not using tamoxifen, we are using an AI. So with AI, the chance of QTC prolongation is nil actually. In my center, we used AIs for all the patients. So we did not come across any of this. So that is the thing that you need to remember. But abemaciclib, like I said, produces diarrhea. So in COVID times, that could be an added toxicity.
That's true.
Yeah.
Yeah.
Okay. So that is where we are with this. And just to prove the point that we have always been talking, this is the study that we are actually doing right now. This is called the right choice. So this is. We have started. We have enrolled one patient now.
Okay.
So that is a patient who is on the chemo arm, getting gemcitabine and carboplatin. So this, I think, although we believe, and there is data from different studies to show that hormone manipulation is as good as chemotherapy, this study was actually designed to show that yes, indeed, this is true, and hopefully we'll get data from this, and we can fall back on this and tell, even in the premenopausal where we would be really tempted to use chemotherapy, we can use hormone management with the CDK4/6 inhibitor. So, what are your thoughts on the design of this study, Ajay?
So this is for symptomatic visceral metastasis.
Yes, absolutely.
So we have already some Indian data that was prepared by Dr. Amit Rauthan on the similar, background. And he has shown his in data using palbociclib that mildly symptomatic visceral metastasis, they did really well on palbociclib.
Yeah.
So probably the design is really good.
Yeah, actually for this study, it is a randomization of those patients in whom you will clinically decide that you will give chemotherapy. So that is the basic thing. So you're tempted to give chemotherapy, but you want to enroll on the study and you have a randomization. Sevanthi, what are your thoughts on this?
I think it's a brilliant thought process, and I would also I'm always torn. You never know. So the patient that you presented, I would have discussed. What do you discuss? You discuss that you'll have to abandon CDK4/6 inhibition if it started that if the patient becomes more symptomatic. There's no quick control. So you prepare the patient because why? Because we don't know. I think it's a very genuine question to ask.
Okay, thank you. Jyoti?
She's already left.
Oh, she has left. Dr. NK, he's also left?
Yeah.
Only 3 or 4 of us are left.
So I think this is a last slide. So our DFS is pretty good then. DFS and OS. So Dole, I think this is my last slide.
Babu, I can just chip in.
Yeah, go ahead.
Because when we looked at mildly symptomatic patient with visceral mats in the Palbo, which we published, me and Amit analyzed, and initially we put in ASTRO, then we went into the JCO Global Oncology. Actually, surprisingly, it is just a mindset change. Initially, we thought visceral chemo, non-visceral hormone. Then we told no problem, visceral asymptomatic. But surprisingly, those people almost did the same as an asymptomatic patient with low volume visceral. So it is just a change of mindset. Looking at this trial you have done, that come out very good, and there is no reason.
So Somsekhar, if you have some patients, please, so if you have some patients, please send them over. We'll love to enroll them.
Definitely, don't enroll in the other arm. Enroll in the CDK.
No, this is randomization, blinded. So, so this is actually another slide which I thought I'll just show. This is looking at physician-reported reasons for choice of endocrine therapy. So they've looked at patient eligibility for chemotherapy and whether they want a break from chemotherapy, patient's age, performance status. So all this we definitely keep in mind, and I think more important in the COVID pandemic times. So I think this is one thing we need to remember. Although this was published in 2014, I think it is pretty relevant even today. So this is something that I got, which is published just this month in Nature Reviews, which talks about the priority of treating various diseases. And I think you should go through this article. It's not very big, but very, very nice article. And if you see here, one end is low priority, other one end is high priority. And if you see, new adjuvant or adjuvant indications are very important. So this is almost tending towards high priority, especially for high-risk breast cancer patients. So whereas palliative indications for colorectal and breast is somewhere in the middle, and all the other things are in the low priority. So I would really suggest all of you to go through this. It's a short article, but very well and written. And
I've gone through this article. Very nice article.
Very nice. Read it. Exactly. It just got published. So it makes sense to actually use it in today's time for prioritizing our patients. So I think that is my last slide. Yeah. I don't think we have any questions.
Thank you, Babu. No
Thank you very much. Thank you.
Thank you.
Really enjoyed your thoughts on this particular topic, and I think we can utilize your last slide for prioritizing our patients for that.
Yeah.
Thank you, Dr. Babu.
Thank you so much, Dole, and thank you all my panelists for the nice interactions.
Thank you so much.
Thank you. Bye-bye.
Yeah.
I think
Thank you.
The last session for today is being conducted by Dr. Ramesh Magada. He will be talking to us about the Onco Collect project and how he has been partnering with various institutions to do the study. Dr. Ramesh, please.
Thank you, Dinesh. And Rajesh has this sudden thought about doing this. Let me see where we are. I'm supposed to be sharing. Yeah, you can see it now. Okay. I have a problem with all this. Anyway, I can't see you all actually.
Sir, can you make it full screen?
Full screen, huh?
Yeah.
Just go down and make
presenter mode.
Yeah, I did. But I can't see anyone on my screen. I can't talk blind. That's the problem. Okay. anyway, these are the institutions so far. We have installed the software, and the one in the blue, or the one agreed to collect the whole data together. We have more than 1 million registration data and about 350,000 primary data on this. And then these are the lymphoma group, and the one in the red are all the ones that have already collected data and presented it, and the other ones are in the process of going through their ethical committee and all. Now, I just want to see what all we have done so far about different things. This was the first paper that Dr. Swarupa Mitra wrote from Rajiv Gandhi Institute, rising incidence of rectal carcinoma in the young age. This was in 2017. She published it. And this was the next one that Dr. Selvi Radhakrishnan presented and published in Indian Journal of Cancer, treatment of elderly breast cancer patients in a breast center in India. And this is the next one, again, that Selvi Radhakrishnan published, and outcomes of breast cancer management from an urban specialist breast center in South India. And this was in Indian Journal of Medical and Pediatric Oncology, 2019. And this was the poster presentation that Dr. Swarupa Mitra from Rajiv Gandhi again did on gastric cancer at ASTRO meeting of 2019. And this is the paper that today we discussed. So these are the publications so far. And the presentations, we did multiple presentations in different places, but let me show, this is the breast cancer upfront surgery, multi-center data 2008-14. That is the one that Dr. Dowell presented in ISMPO-ISO conference indoor in 2019 November. And this is the Oncocollect lymphoma group registry data. For Hodgkin's lymphoma, Dr. Reena Nair presented in 2011-16. And again at indoor conference. And this was the, again, lymphoma group registry data, diffuse large B-cell lymphoma, 2011-16. Dr. Senthil Rajappa presented at RGCon 2020. That's the latest. And multiple people presented diffuse large B-cell lymphoma. From the first presentation we did actually in Jaipur, ISMPO, Dr. Reena Nair in 17th November 2018. And in this, you can see the number of patients we had. We had large B-cell, about 656, and 346 of Hodgkin's disease. And then this is the one presented by Dr. Senthil in February of this year, where we had 64,169 patients. And in this, we nearly have 1,000 of Hodgkin's, and we have 1,600 of large B-cell. So just want to show you briefly how we have been progressing, and breast data collection in 2 institutions on a single platform. This is Senthil Rajappa and Dr. Manisha Singh from Hyderabad and Patna. And they collected from 2017. Now this is ongoing. That time we had about 4 months. In that 4 months, we had 590 patients between the 2 institutions. And just to show you that now we have more, and 2017 is being completed. And the Oncocollect, again, collaborative group cancer cervix 2017 data. Dr. Reta Rani from Mahavir Cancer Sansthan presented at ARI 2019 Ahmedabad. And again, in this Mahavir Cancer Sansthan, Rajiv Gandhi Cancer Institute, and Indo-American Vasudha Pinda and Saraj Gupta Cancer Center are partaking. And the methods, this was again from 2017, and we had about 800 patients at that time. We have much more now. In 2017 and 18, we should be having around 2,000 plus. Hopefully, we'll write it up in the next years. So these are the things that I really had to say of what we have and what was done. Now, I would like, how do you get back onto this? Okay. Anyway, I'm not able to see. Rajesh, can you tell me how I'm supposed to see the people on anyone around?
You can close the screen share.
Screen share, okay.
Yeah.
Screen stop.
Please.
Fine. Yeah, now we got on. Yeah. Now Dr. Swarupa Mitra is there at Rajiv Gandhi, and I would like few of the people that are that have been using this to comment, and anything that can tell. Hope is that people can see that many people are doing it, and we are able to produce things, and eventually we will improve. That's what I said. Maybe Dr. Swarup Mitra, maybe you can say a few things.
Good evening, sir.
Yes,
Good evening, sir. Can you hear me, sir?
Yes, yeah.
Okay, sir. So thanking you, sir. Thanks a lot that you have given me the chance to speak about my views of the Oncologic Collect, and which is gradually becoming one of my favorites. So let me start. When I was first introduced to this, I was a little reluctant. Learning a new method, new software was really a headache to me that time. But somehow when Sir Dr. Ramesh showed me this, the first thing which attracted me was the friendliness. It looked very friendly and very attractive, not like the Excel sheet or most of the data collecting tools we have. It was very attractive. And then gradually, I started liking it. First thing was that, yes, like I said, it was very attractive, very easy to use, very friendly. And I used it what I wanted. If I wanted to see a particular group of patients, a set of patients, I could select them. But of course, it took a long time to really add to it and to learn it. And initially, the radiation data was not there. And Sir had been Dr. Ramesh, Sir had been so friendly, and he has been so available all the time. Anything I needed, like the radiation data, was a little different. So whatever I needed, Sir added, and very promptly. And what I mean to say, there is always that ease is there that I can change, and I can tell Sir that this is what I need. And every site may be different, and the radiation procedures are different. There are newer data and newer way of doing, so everything can be assembled over there and seen. And the latest was the addition of the statistics part. That was added to the beauty of it. Initially, we had to go to the SPSs and collect data. And I remember one day we had sat with Sir and we were discussing that, Sir, let us have this SPSs. And Sir also said that, yes, I am thinking about that. Yes, let us add the statistics to it. And I think that completed everything. But I'm sure even I know many things I do not know till now. And I take the help of my data collecting girl who is actually doing it, and take the help of Sir also. And I keep on learning. And I think now cervix we are doing, we have collected in 2011 to 2019. These many years data we have collected on OncoCollect, and with a lot of ease. So I think this is what I have to say.
Okay. Thank you. I don't know if Dr. Rita Rani is there, Rajesh?
She is there, sir.
She was there, yeah.
Yeah, madam, you can unmute yourself. Yeah. Dr. Rita.
Yeah. Am I audible?
Yeah, sure. Yeah. Okay. Go ahead.
Thank you, sir, for giving me an opportunity to talk, first of all. And I'm really glad that I'm connected with OncoCollect. And I completely agree with Dr. Swarupa Mitra that this software is like very friendly, very easy to use. And then it is like the cervical data is being collected by my radiotherapy technician, and who just asks few things, and that he has learned it very easily. And it is easy to use. And best part is that what I used to think that we are treating quite many cervical cancer in my hospital, but when we actually analyzed our data, and when we had to present the data of 2017 in the OncoCollect, I found that the numbers are not like the numbers we usually treat. Then it was like, okay, we are treating patients with all, like be it palliative, radical, stage 1 to stage 4V, and so many. Then when we are actually combining data, we are getting to know what is actually the real world data. And as Sir has encouraged us to do the things, probably we'll be coming with the real data as we saw in that breast cancer patients. And the best part was that when we were analyzing the data, Sir constantly kept us guiding, kept in touch, what is to be done, how it has to be modified. Being a medical oncologist, trying to understand what all we do as a radiation oncologist in cervical cancer. So Sir is always very ready to learn whatever new things we talk with him. And when we analyzed that data, we found that still 80% of the patients are still receiving conventional radiotherapy to the pelvis, followed by intracavitary radiotherapy, in spite of so many advancements in our country. So these are all amazing facts which we got to know. Like very few patients are taking 3D CRT and IMRT. Most of them are undergoing conventional radiotherapy still. And above all, what we saw that is it's a kind of uniformity in the treatment. We had collected data from all four corners of India. One from Delhi, the other one from Kolkata, the other one from Hyderabad, and one from our center, Patna. But the uniformity of treatment is like quite good. It's amazing to see, and there are some. I think this data is going to come out beautifully, as I was telling. In a couple of months, we'll be able to publish as we have collected more and more data. So that is all I have to say, and I feel good to be a part of this project, and I wish more people join hands so that we can have a larger data for the greater benefit of our patients, of our country, the patients of our profile. We are always seeing to the Western world for the data. Thank you, sir.
Thank you. Thank you. Is Manisha Singh there, Rajesh?
Yes. He was there.
Okay.
He was there, but I don't find her. No?
Okay. Anyone else? Who else is there? Dr. Ramanan there anyway?
Dr. Selvi is there.
Selvi, yeah, right.
Dr. Sevanthi is there.
Okay. Dr. Selvi is.
Yes, she is there.
Okay. If she can.
Dr. Selvi, unmute yourself.
Good evening, sir. I'm here.
Right. Yeah. She was the driving force for us.
So the easier part for me is that we restricted to one organ practice. So and surgical practice that we started collecting data from 2007, and like someone mentioned, it is all in an Excel spreadsheet, and just one of the meetings I shared the details with Dr. Ramesh sir, and then that's when the follow-through action happened. So the challenges for us as in a surgical practice to collect data is like once surgery is done and the patient goes for adjuvant therapy, then they don't come back to us, and therefore for us to start with in the early years to ensure that we had the follow-up in our hands. And I mean, of course, they would follow up with the medical oncologist, but to keep calling them and bringing them back for follow-up. And so that was a challenge, and somehow we managed to create a kind of protocol so that worked for us. And two, I always feel that doctors are the most unreliable people to record data, and doctors should be only cross-checking data. I think we should have our particularly if you rely on junior doctors, it could be very unreliable. They come and go, the trainees come and go, and the commitment is not uniform. So I, very early in my practice, trained two nurses, and because they stayed with me and they continue to stay with me, they know the processes behind what we do, and they understand it completely. So they actually, one person does, we still continue to collect the data in Excel sheet because for various things that is also useful. And one person does the OncoCollect and one updates on the Excel. And every week I sit with them, sometimes once in every 2 weeks, I sit with them and then randomly cross-check and do a few things with them. So this has ensured that the data, and as and when we see every day, I update the status. End of the clinic, those books are kept separately, and that day itself it's updated. and the new registrations also continue parallelly. So that is how we've ensured that the data collected is optimal. And of course, Dr. Ramesh sir's office is just 10 minutes, 5 minutes away from us. So every now and then we would just go to his office with various things. So it's been an amazing journey, and I wish we do more. Thank you, sir.
Thank you. Dinesh, who else is there? Ramanan is there?
Ramanan is not there.
Okay.
I think Dr. Sevanthi is there. Anything, Sevanthi? Would you like to unmute yourself? And
So I'm truly inspired by the work that was presented, the 3,000 patient data, the work that has been done, published and presented. Really inspiring. And I'm also very inspired by the OncoCollect study. Actually, I was just typing for all the panelists, how could we at Kokila participate in this study? So really thrilled. I think a lot of work is happening. This is what, initially when I came, I was trying to figure out the Indian patient data, and we lack it so badly. So I'm just, I can't tell you how inspired I am, because I've always felt limited, but the kind of work you're doing just says that there aren't any limitations, that if you're out there, you can figure out. And the fact that you've collected so many centers, I think there are 20, 30 centers that you've put together. And once we learn how to collect the data and how to collate it, so we'll be a force in the world. And I see that happening. 3,000 and over breast cancer patient data now. India, we do have a story to tell. So I'm speechless.
Great. Thank you. Yeah, if you want to join, it's not a problem. You just have to write to me. That's fine.
Yes, sir.
We'll do that.
Sir, can you share how many total patients are there now in the data?
In the data, we have 1,040,000 registration data, and we have about 340,000 site of primaries identified. But more than that, I think in the last 2-3 years, we have almost 80+% of patients who are treated. Their primaries identified, so we can actually now go and say 2017 and 18, these are the patients that you have treated in your hospital. Now get the data into the system. And that's what we are doing now with the surveys we are going to do. And hopefully by the end of this year, we will complete nearly 2,000 to 2,500 properly treated data from the surveys between these 5 institutions. And we will actually publish it. That is the whole idea from now on. And Dr. Reta Rani is the in charge for it.
Thank you, sir.
Right. Okay. Yeah.
Ramesh, anything else?
No, that's fine. Thank you, Dinesh.
I think I remember, I think you remember when I showed you some of my diaries where I was noting all the patients from 2000. So I have a record of even the patients who are at the earlier point of time. But let's see if something can be done for all those people. But I think it's really inspiring that all of us could come under one banner, and there are youngsters who are also willing to join us. So I think we can have more forceful data that should be available.
That's what we felt, that we show this and people will, they should see that it can be done.
Yeah.
Till now, everybody were very unsure what we can do. And sure, there will be a little bit lacking all over the world. They went through decades. It just didn't happen. So it will all come.
I think one thing I did not tell you earlier, that this data collection we started with the help of Aventis, which is now, because I was a user of Taxotier, so, and then subsequently taken over by MCure. So today they are also a part of our data collection, which has gone over the years. And now to end the session, I would invite Mr. Sanjeev Kathuria to say a few words. And Dr. Ramesh, thank you so much. And I think let's have a good cooperative work. That's the key to success. Thank you.
Thank you.
Thank you, Dr. Doval sir. And I deem it a great privilege to extend a vote of thanks to all honorable dignitaries as well as the delegates. The number which we got, almost 645 delegates have attended. the live webinar session, both from domestic as well as the international delegates have also attended. Now, on behalf of entire MCure team, I would like to give a big thanks for making it a great success. Now, I would request Zoeb to take over for giving the closing remark. Thanks a lot, everybody.
Thank you so much, Sanjeev ji. Thank you. I would like to express my gratitude to Dr. Doval sir for organizing such an insightful event. Also, would like to thank Dr. Ramesh Nimaganda sir for giving his consent for presenting the small part of his data, which was very helpful. And would like to thank moderator and panelists for having such an engaging discussion. Also, I would like to give a major thanks to Rajesh Sharma and MICE Ideas team for collaboration in conceptualization and execution of such event, of such a fantastic event. And MCure promises to have more such events in the coming days. Thank you so much, everyone, for the meeting.
Okay, thank you so much.
Thank you, sir.